All right, good morning, everyone. This is the panel on surveillance, which we've all been looking forward to. I'm not going to introduce the panelists to you. Their bios, their biographical information is in your materials. They're going to be speaking in the following order. This is Nate Wessler, immediately to my right. Kalia Hamlin at the end will go second, and Paul Haddis will be third. Just to tell you briefly where they are from, as I say, I'm not going to give you their biographies. Nate Wessler is at the ACLU. Kalia Hamlin is with the Personal Data Ecosystem Consortium, and Paul Haddis is at Tufts University Medical School. I want to talk briefly about why we have this panel. Why is medical data important? I was at the OECD in Paris, which has, at that point, had 25 member countries. It's an international organization, a treaty organization, the most developed countries in the world. Now there are about 30 members. And one of my jobs was to look after privacy. There were a number of privacy international accords and national legislation by that point. So we had meetings every year on privacy, and I would choose a different subject and cut at it. And so in the early 1990s, either 1990 or 1991, I chose the subject of medical privacy, now more often called health privacy or health information privacy. At that point, it was called privacy of medical data. And we chose that as a subject. And so quite typically at the OECD, we would ask member governments if they had any, well, we would produce documents, we would write reports, the Secretariat, and then we would ask member countries if they wished to submit what were called room documents. And so those were submissions, informational submissions or whatever from member governments. And with a controversial topic, you might get two room documents. So very rarely, once in a while, you would get some room document or two from one of these 25 countries. So for the medical privacy meeting, I sent out a request and said, would anyone like to submit any room documents? And we had 35 room documents. 35 room documents came in, and it revealed to one another this incredible wealth of activity that had already been taking place for decades with regard to the computerization of medical records. So starting in the 1970s, and this was in 1990 or 1991, the huge amount of research and thought that had already gone on in the OECD member countries to protect medical records and within their computerization. So we had many, many examples of that. This is not an old issue, a new issue, this is an old issue. And why is medical data important? So it's obviously of importance, and you all come to it from different perspectives. But I'm going to speak just from my perspective for a minute, where I come from and thinking about medical data. Medical data or health information is a massive load of highly sensitive personal data. That's what makes it so interesting from a privacy perspective. And it's a very hard technological problem in that sense, although it has become increasingly simple as a technological problem over these recent decades. So it's similar in that way to money or voting. Those are also some of the more difficult or have been the more complicated technological problems. And if we can sort out how to protect health information, how to do online voting, how to have digital money that's robust, then we've solved a lot of other problems in the ubiquitous information environment and in the exchange of information. So that's why one of the reasons we're talking about medical data today. I want to remind you of, as we're going to enter into this discussion about surveillance in particular, of a few of the basics with regard to protection of personal data and information. There are two big axes that underline the entire field, and they are that the individual, in my view, must control and own her personal information. And there are places on Earth where that is done today, although not in the United States. The second grand strut that underlies this whole area is that of proportionality. In other words, that the solution that's developed be in some way proportional to the harm or the problem you're trying to address. Because also if we tend to over-solve or create over-solutions, then you start to create additional vulnerabilities. Some of the basic concepts of data protection and privacy are notice, that the individual be given notice. And it was very interesting to me yesterday morning in the discussion, one of the speakers yesterday was saying, well, notices are so lousy, notice doesn't work, we shouldn't have notice anymore. That's not the problem. The problem is we should have notice, but we need to be much more effective in the notice we give. So there's notice, individual choice, and individual consent. When information is collected, the purpose must be identified, Only the information for the identified purpose should be collected, and only that information which was collected for the identified purpose should be used. No fishing expeditions, no secondary or tertiary uses. These are basic concepts that are well accepted throughout the world. So I wanted to remind you as we're starting that discussion today. Now, moving specifically to surveillance in the ubiquitous information environment, I'm going to turn it over to these speakers who are ready to go in just a moment. Surveillance is pervasive. I like to talk about the ubiquitous information environment. So what is that? That's a pervasive information. So computing will be going on in the air you breathe. This will be a computing device. Liquids in the air you'll be breathing in and out. Computing activity, some of which will reside within you, some of which will move out and move somewhere else or whatever. Others will be able to monitor your internal states, as happens already, and it'll be communicated elsewhere. So in terms of the granularity of information collection, including about your physical or mental health state, it's going to just increase. Right now, already, the NSA has, in addition to all the other things that we are all reading about and that you're going to hear about, they have what they call a social graph. They have mapped all relationships in the world. This is trivial to them. And this exists today. And I urge you to go look up Bill Binney's name, William Binney, who was a senior official at the National Security Agency, and there are plenty of YouTube videos of him talking about this. So these are the kinds of, this is the environment we're in, one where all social relationships in the world not only have been graphed, are being real-time, continuously graphed, continuously monitored, so that all of your relationships are known. And we have an environment where computing is literally everywhere. So with that in mind, I'd like to turn it over to to Nate Wessler, please.
Thank you. And thanks for the chance to speak today. In my work at the ACLU, I'm largely concerned with regulation of law enforcement access to sensitive data, which is what I'm going to talk about today. And I want to talk in particular, to start out, about law enforcement access to state prescription drug monitoring programs. 49 states have these databases. Missouri is the outlier, and they track information about controlled substances prescriptions issued by a pharmacy to a patient. So that's drugs that are on the federal controlled substances list, which range from opioid painkillers to Xanax to Ambien, testosterone, Tylenol with codeine. And so every time in these states, every time a patient fills a prescription from a pharmacy, the pharmacies are required to electronically report personally identifiable information about the patient tied to information about the drug they received, dosage, refill information, et cetera. And it resides in state-controlled databases. Now, this audience, you all know well that knowing information about a person's prescriptions can reveal a whole lot about their underlying medical conditions, and that can be very sensitive information and very private, and strict controls, I think we all agree, are important. Now, there's certainly a public health use for these databases, these PDMPs. Doctors, for example, can look up a patient's prescription history and see whether they have been doctor shopping for an addictive drug or whether they have other concerning prescription history. But law enforcement is also interested in access to these databases in order to investigate doctors who they think may be illegally prescribing certain of these controlled substances, or patients who they think are fraudulently obtaining them. But law enforcement access, when it's not adequately regulated, raises a couple of concerns. One is a policy concern that it can end up deterring patients from seeking care. But the other is a concern under the Fourth Amendment to the U.S. Constitution, which protects the privacy of this kind of very sensitive data and requires police to get a warrant from a neutral judge based on probable cause when they want to access this kind of information in an investigation. States vary widely in what kind of protections against law enforcement access they impose as a matter of state law. So 10 states require, as a matter of state law, require law enforcement to go to a judge and get a warrant or to otherwise demonstrate probable cause. There are a number of states in sort of a middle zone that either require a court order on a lower standard like reasonable suspicion or just a subpoena. And there are a number of states that let law enforcement directly log in to these databases or request access without any kind of legal process whatsoever. And I want to just finish my introductory moment here by talking about one case in Utah that we've been involved in that really beautifully and tragically illustrates the danger of poorly regulated law enforcement access to these databases of this information. The Unified Fire Authority is a large unified fire and rescue district surrounding Salt Lake City. A number of towns and cities are part of it. It has a dozen or maybe 14 fire and rescue stations with a bunch of ambulances. And they discovered that several vials of morphine had been tampered with in a couple of the ambulances, and the morphine had been drained out and saline had been put back in. So they called the police to try to figure out whether it was one of their employees who'd done it, maybe a patient who'd gotten access, what had happened. Police weren't able to figure out who might be a likely suspect through traditional investigative techniques. And so one of the local police departments, a local cop, decided that the next thing he would do would be to directly log in to the Utah Prescription Drug Monitoring Program, which under Utah law enforcement can do without going through any kind of legal process. And he downloaded the prescription histories of every single one of the 480 employees of the Unified Fire District, 480, without an attempt to even narrow down to who had worked in the firehouses where these ambulances were or anything. And he looked through, I guess, for a history that suggested that they had an addiction to an opioid painkiller that might have suggested that they had taken this morphine. He couldn't find anything sufficient to make that linkage, but he didn't stop there. He decided that he wanted to sort through these records a little more and see if there's anything suspicious enough to bring charges against someone for something. And so he continued to just look through all these records and identified 3 firefighters and paramedics whose prescription histories he thought were suspicious enough to try to bring charges, and he was able to convince a prosecutor as to 3 of them. We got involved on behalf of one of these paramedics, raising these Fourth Amendment arguments about how this search was illegal. And the evidence that they were able to get kind of illustrates the ridiculousness and the danger of this kind of access. He had gotten a painkiller prescription from his general practitioner for, I think, a work-related injury. He had then subsequently had oral surgery, and the oral surgeon had given him a post-operative prescription for another painkiller. Neither doctor thought it was a problem that the other doctor had prescribed, but this police officer thought he knew best, and so convinced the local prosecutor that this paramedic was fraudulently obtaining narcotic prescriptions, and they've now brought charges against him. And so he has suffered not only the indignity of an illegal search, but he now is mired in probably years' worth of criminal defense to try to get himself out of this mess. And we're doing what we can, and he has good defense attorneys, but it really has turned his life upside down. So I'll stop there for the moment. There are other cases elsewhere in the country. There's a case we recently won in Oregon about whether the DEA can access a state prescription drug monitoring program without a warrant, even when state law requires a warrant. And I'm happy to talk about that later, but I think these are pressing issues, and they really go to the privacy interests that we're all here to talk about.
Fabulous. Thank you very much, Nate. Kalia.
Actually, I wanted to put up a couple slides, so whoever was bringing me a USB key.
Do you have a flash drive?
I do. Well, no, I don't. I need a flash drive to put it on the system, right?
I'll go find it.
Okay, thanks. So what I wanted to put up, and hopefully we'll get it set up, is there's a real problem with the frame that I think we're in. We're in a frame that's anchored in 1973 when the original FIPS were articulated, and we need to get out of that frame and get into the present that we're in. And I think we need to well, I'm supportive of all the efforts to sort of work on notice and consent and informing consumers of what they're doing. We also need to start talking about our rights to data, and that it's very clear that different entities that transact with us will have copies of data about those transactions. And right now, there's so much information asymmetry between us and them that's an issue we need to be addressing. In 1973, none of us had computers in our homes. 10 years ago, almost none of us had computers in our pockets, and now we do. But when we go and we buy a coffee at Starbucks or interact with our doctors, we get, at most, a piece of paper. We don't get an equivalent electronic version that helps us build up our own profile of who we are and our own data footprint. And so I think, part of what we have to do is talk about data rights and data responsibilities, and also consider the anchor that we're which part of the law are we anchoring the conversations in? If we continue to anchor them in property law, we're anchoring them in a world of atoms. Either he has this water bottle or I have this water bottle. And in the digital world, we both can have copies of the same data, and it doesn't infringe on one or other of our rights or our ability to have it. And so I think that, you know, in getting to how we sort of address issues of surveillance, we don't have the capacity, or we're not being given the rights to our own data as we move about the world, so we can sort of surveil ourselves and take back power and then manage how other people see us. So those are my comments, and I'll put up the FIPS in a minute, hopefully.
Okay, great. Thank you very much, Kalia. Paul.
So I guess hearing Nate initially talk about legitimately the concern about people like law enforcement getting our individual information they shouldn't, and Kalia talking about how do we get the information that we don't currently have, both also a very legitimate concern. I guess I worry about both sides of those things, but let me tell you how I'm coming at this. Although I'm listed as a Tufts University professor, which I am, and in public health and public policy, I wear a couple other hats that I come to thinking about this conversation. One of those hats prevented me from coming yesterday. I'm one of the initial founding commissioners on the Massachusetts Health Policy Commission, the Stu Altman chaired commission that our state and healthcare reform 2.0. We did the access bill in 2006. 2012 we did a cost containment bill, and our commission is empowered to do certain things under the guise of, or the desire to control the growth of healthcare costs. And so I think about some of these issues in front of us today from that perspective. But the main reason I'm here, and Andy Oram and I share, is that we're part of a consumer organization called the Greater Boston Interfaith Organization. I mean, we're sort of lay members, and in fact the members of our only congregations, primarily churches, synagogues, a mosque, a couple labor union groups, and community development corporation organizations, who works on social justice issues, although GBIO has spent a good deal of time over the last 10 years working on healthcare, and really its involvement with that organization, where we've been talking about what is it that consumers want in a socially just way about the healthcare system that sort of guide what I want to share with you. So in one of those conversations, we at GBIO over the last 8-9 years have said, you know, when it comes to the healthcare system, it's our money. It's not theirs. You know, all the stakeholders out there think that it's, you know, doctors, hospitals, insurers, it's their money. It's really not. It's ours. It's our information, and it's our community responsibility. And I see what I'm chatting with you about here briefly, and then we'll hear from our whole panel, is the our information part. So in GBIO, again, these are not IT professionals, although they include that, like Andy. They're not all healthcare providers, and I sort of come a little bit from that realm. You know, it's a broad array of folks sitting around a table trying to work on social justice. But we did talk about, I'll also name some of the issues we did talk about in this one discussion, which is emblematic of maybe both sides here of what Nate and Kalia gave you. We talked about having control over our own personal health information and who gets access to it. And here I'm talking, I guess, really primarily in the identified information realm. 2, we want an ability to place that information in a secure place, probably on the web. For many of us, we can talk about why that's probably important. And although I put initially ask, maybe I should say require providers and others who have that relevant information to send it to that place that we designate so it's available for us to control. We, the consumer, ought to be able to share that information with providers and be able to do so when we choose, even selectively as to what we share. Although I say this with my physician hat on, that can be complicated. People's care might be for the worse because they're not sharing information, although that's always been an issue, you know, in terms of what people are willing to share. The cost containment role, I said Health Policy Commission, is that we might, by not sharing information or decide to do it selectively, cost us all have to pay more in our premiums potentially, you know, so it's not only affecting the individual. Maybe we can come back to that. Another hope is we want an effective EHR, electronic health information system, that respects our wishes and our desire to maintain privacy. In Massachusetts, we're pushing not only all the hospitals to be on the e-highway, but physicians connected to those hospitals. And, you know, and maybe this speaks wonders about where our Health Policy Commission is in, which is we have not yet had a discussion from a policy perspective about the issues that we're talking about here today, in terms of, you know, really worrying that much, at least on our radar screen, about issues of privacy and the like. But, you know, those doctors that are hooking up, and we worry about, you know, what kinds of protections they have, and, you know, the ability to exploit somebody's information system and do medical identity theft, or to do something else that, you know, is potentially not in our interest. I think we would worry about, and we worry about those EHR systems. We also worry about that those EHR systems are proprietary. So, you know, I get cared for today and hospital system A, and, you know, there's huge battles going on in Boston over, you know, patients and money and all that, but I cared for at hospital system A. But tomorrow I'm presenting in front of a doctor from hospital system B. That information isn't going to move from hospital system A to hospital system B, even though they both have electronic health information. And in fact, hospital system A might not want to lose this as a patient and lose that global payment, and want to make it difficult to move information from A to somewhere else. So we'll, you know, have to stay with them as opposed to bring our capitated payment elsewhere. You know, at least that's in theory a worry. I guess I could go more. There's some other issues, but let me end with our own story, though. In the Globe earlier this week, and, you know, and this talks to the issue, I guess, about having access to information, was an opinion piece by a gentleman who right now, because he got exposed to measles, and he's being quarantined, and he's been trying to get, he's probably, I think, in his early 40s, to get a paper record from his mother or some other place that shows that he was actually vaccinated years ago, so that he can't, you know, he's protected against measles. Well, that piece of paper can't be found, so right now he's under quarantine because there's no way of proving that since he's been exposed, he could get the illness and then ultimately, you know, pass it on to others, cause a measles outbreak. So the point is if that information, you know, that didn't exist, or the web didn't exist 30, 40 years ago, but if today somebody gets vaccinated, becomes part of your permanent record, he wouldn't be quarantined right now. So, you know, there's other aspects of ACOs and de-identified data, and the alcohol drug abuse patient record issue, not touched fairly since '87, and the discrimination legal consequence issues, which I'd like to talk about, but let's get into that from questions. Otherwise, I don't want to monopolize our initial discussion here. Thanks.
Okay, excellent. Thank you very much, Paul. Thanks to all of the panelists. I asked them to speak for 5 minutes each so we could bring you into the conversation as early as possible. So I'd like to open it up for questions. Please line up at the mics if you'd like to ask questions or make comments. I'd like to just, while people are coming up to the mics, I'd like to ask you about genetic information, you know, because that also has the additional element. Oh, and first of all, let me remind you, all of you, that this conversation today about surveillance of health data is taking place exactly 1 year, June 5th, from the first information that the public was receiving about the materials that Edward Snowden had taken from the NSA. So it was actually in the Washington Post and the Guardian and so forth. It was 1 year ago today that all of that was happening. So very timely. Let me ask you, though, about genetic. I want to widen this conversation a little bit right away about genetic information, because that also implicates third parties, you know, who aren't the direct patient. Comments or on that? Perspectives on that in terms of the surveillance implications, because there you could have a situation where an individual patient may or may not know that they're, you know, being treated or that their records are being looked at, but with genetic information you're obviously implicating you know, anyone genetically related to them. Any comments on that?
So you're saying that it's not only being able to analyze somebody's genome and predict future health issues which could cause discrimination or legal consequences in some way, by saying that if my genome is read, it has implications about others that are biologically related to my genome, and I'm giving, in some ways, disclosing things about them as well.
Absolutely.
Yeah. You guys want to comment?
I mean, I approach.
Thanks for clarifying, Paul.
I've named the problem, so.
I approach all these questions from the perspective of, you know, what should law enforcement be able to obtain and when and how. You know, I think with genetics, there's a question about, you know, direct collection, coerced or mandated collection by law enforcement, for example, in a criminal investigation where they're trying to match a DNA profile to evidence at a crime scene. You know, whether they should be able to collect samples from suspects and on what level of suspicion? Do they need a warrant or just reasonable suspicion? And then a question of access to databases of genetic information held by government entities, private entities, the sort of 23andMe companies that now are holding probably a whole lot of deeply private genetic information about a lot of people that may not have turned out to be that useful diagnostically, but certainly can be pretty intrusive. And so there are yet not good answers, and the courts have just barely started to wade into this area.
So what comes to mind is a kind of creepy use case that I heard about at South by South, or I heard was discussed at South by Southwest, which is marketing companies going in and sort of swabbing products in stores to figure out who was touching them by analyzing the genetics that were left behind. So not necessarily the specific people, but figuring out which people from which ethnic groups were interested in what products. So, as soon as you touch sort of genomics, which is in all of the skin we leave behind everywhere, like these things, all biometrics, most biometrics are not secret, right? So we share them all the time. There are my fingerprints. Look at my eyes, right? So I think they're misunderstood in terms of how we have conversations about how we manage them and how we protect our, what are the rules? And we're not having a clear conversation about them because we keep thinking they're sort of secret and ours, and they're not.
No, in fact, we're all shedding DNA all over the room, right? Adrian.
This is an opportunity to actually, and a very appropriate to this panel, firsthand experience with respect to surveillance of healthcare data. And I'm very glad to see Paul on the panel. Relative to Kalia's comment, there is in Massachusetts an all-payer claims database, which is one of the 3 government-mandated councils or aspects.
Our Health Policy Commission is trying to, we hope to learn a lot from that database. So.
And when that law in 2012 was being I put in, with the help of my congressman, a clause that patients would have access to the information about them in the all-payer claims database, in this surveillance entity. About a year ago, while this thing was now operational, I went and spoke to the person running the all-payer claims database, and because they had not put in the patient access provision of the thing. And I was shocked because for the first time in my life, actually, they had the general counsel in there at an initial meeting. This was not, this was a big deal, interesting for me. And the answer was basically, the reason we did not put in this feature that's in the law is because it's too hard.
And it's not an issue, it's not an implementation rollout issue. They're saying it's never going to be, to their perspective, it's not going to be made available to all ever at this point.
I don't want to take the whole time here. I'm happy to go into the specific details. We have a legal scholar and the
Right. So
I can go into the details. I'm just trying to basically pose the question that when it comes to surveillance and fair information practice, where you have government acting to do surveillance in healthcare and ignoring even the most elementary aspect of fair information practice, namely transparency, when specifically listed by law, what we end up with is that people pick and choose the council. And I tried to speak to the person who runs your part of the operation. They didn't even want to speak to me. I'm forgetting his name. So what does this say from an ACLU perspective about how these things are governed when they relate to healthcare, how they're implemented when, as you are, and I'm sure you're on the right side of this, but what is the limitation from your perspective as a trustee of this process? That's my question.
Okay. Did you want to take the...
No, go ahead.
Well, the part that I'll say is, because I'm fighting my own battles about if it's in the law, then we ought to have it implemented. So, I will leave that, the specifics of that, and maybe you and I can connect around that afterwards. But it raises the general question, which is, I do think that, and the law, whether the law says it or not, but in this case, especially where the law says it, if individuals have a right to that surveillance information, and are you trying to get at it from the perspective of a person has a right to get at it as a researcher, get at it as my data sitting in the database? So
that was the executive director, first question. And the reason I want it is because Massachusetts has a health insurance exchange for many years, right. And the information in the all-payer claims database would allow people to choose which plan, to know retrospectively what their out-of-pocket expenses would be. Right. The software that would be required, whether the state provided it or my accountant provider, would be trivial for me to see the 30 choices in the health insurance exchange and what would have been my out-of-pocket cost for each of them, so that at the re-sign-up time, people could save a few $100. And I've written about this in the healthcare, in the BUR on the radio station blog, as to how I could extrapolate savings of hundreds of dollars per enrollee if they could pick based on the information in the all-payer claims database. So this is not.
Let me broaden your question, and maybe Nate wants to make a comment, which is, I think identified data versus de-identified data, we are in two different lands there, okay? And I do think, though, if you're saying, should you as an individual have access to the same de-identified data that health plans and hospitals or others have to try to make decisions around, I would say we, as individuals, we ought to be empowered.
There's nothing de-identified about data in the all-payer claims database. The whole point of it is that they're aggregating information from all of the places where people are spending money. And the law and the purpose of the database is, there's nothing de-identified. I'm not talking about research uses. I'm saying the clause is what Kalia said. It is, can I have symmetry so that if I have my own software or my own accountant acting as my agent, can I save those $500, $600, $800 a year, maybe thousands in some cases, by the benefit of the surveillance that's being done under the law?
Right, but the surveillance under the law, just to understand what your point is that you're saying you ought to be able to access that database with identifiers in it.
He wants his own data.
Oh, get your own data out of it.
Pardon?
You want your own individualized data. You want to be able to make a data request to say, I'm Nate so-and-so, here's my social security number, somewhere
Maybe
in the
you should put up the fair information practice at this point.
Yeah, okay, all right. So I'm going to think about that, but I don't see why not. In other words, if it's available to you and the law requires it, you ought to be able to get it. It seems that's a straightforward question. So.
Any comment, Nate?
That seems to sum it up. I think there's, with any government function, there's an important value of transparency, and when we're talking about our own data, there's a particularly compelling reason to have access to that, as long as all the other protections on privacy are unaffected by that.
So Kalia's put up a slide, maybe more efficient than having to ask every, as you say, provider to upload information. You can get it all from the all-payer claims database in one request. Why not?
So. It does seem appropriate to pull this up and share it with you.
Can you lower the house lights?
A little bit, because they're really good words. So I came across this paper, and it's referenced on the slide before, called A History of FIPS. And what's great is reading these 1974 principles, because it says there shall be no personal data record-keeping system whose very existence is secret. And this language about personal data record-keeping systems is abandoned in all subsequent versions of this. And so the fact that we're talking about these systems kind of gets lost and abstracted as we go through time. And I totally invite you to go and look through them, but so they changed, right? And then we get the OECD principles, which just start referencing personal data. and stop talking about record-keeping systems. And then the Federal Trade Commission recommended these principles for commercial websites. So there's only 4 that they pulled out. And then the DHS version of FIPS sort of keeps changing more, focusing on PII, personally identifiable information. And then the NSTIC put forward a set of FIPS, the National Strategy for Trusted Identities in Cyberspace. Jeremy was here yesterday speaking to us, and both myself and Adrian are on the Management Council. They watered them down. So they're not current, and they don't they don't come from a place of where technology is today and where it's going. And I think we need to, like, I've been talking about a term, to regulate forward. So we look ahead to where technology is going, which is what you're talking about, and what, where is personal health tracking going? We put these forward to think about principles for a personal data ecosystem where people are collecting and managing their own data as well. And that the word and term I really like to focus on is dignity. And also this other piece, respecting relationships. We're talking about relationships between patients and their doctors in this context a lot, and patients and the people paying for care and the people they work for. And we need to understand these systems and make them work for those relationships. And then these are just some of the last ones. So I'll give these slides to Deb, and you can have them up on the website. So.
Thank you, Kalia. Next question.
This is for Nathan. In addition to the prescription drug monitoring databases that states have, I gather many of them have quite elaborate public health surveillance databases too, clocking who's been vaccinated and who hasn't, AIDS status, sexually transmitted diseases, all kinds of other things. And that some states and cities are even using these not just passively but actively to contact citizens whose A1C scores are too high. And has the ACLU brought any cases or any concern about those, or is anything that's done in the name of public health fair game?
So I'm not aware of any work that we've done directly on those, although we have 50 state affiliates, and some of them may well have done work on a local or state level. I do think that the purpose of collection and the protections put on the data matter in these contexts. And so, I think there's properly some more latitude around public health efforts than there is around law enforcement access for punitive reasons. But that doesn't mean there should be carte blanche to, collect everything and anything just because it's possible. And it matters a lot whether the data collected for a public health effort is restricted solely to that, and there's a firewall put up so that other government agencies can't access it, right? If you're there's a public health initiative to make sure that people with HIV or AIDS diagnoses are getting appropriate follow-up treatment. That's as sensitive as can be, and it's not only embarrassing, but can result in lots of kinds of discrimination. So. There may be types of information that we don't even want public health officials to have access to in that kind of a mandatory broad way. But I think it's less concerning than some of the other types of government access that we've seen.
Good. This may be a good moment. Would you take a minute and tell them about what went on in Oregon?
Yeah. So Oregon was interesting. So Oregon has a great, relatively good privacy law around its PDMP, requiring law enforcement to go to a judge and get a warrant before getting access. The DEA, though, loves these state databases and had been insisting that it had a right to access the records in the database in Oregon with a subpoena, which does not require going through a judge at all. It's just a piece of paper issued by the agency. And the DEA was saying, we're not bound by this state law. We're a federal agency. Do whatever you want in your little state, but we want these records and we want them now. And so the state of Oregon sued the DEA to figure out whether, in fact, they could rely on their state law and not give the records over. And then the ACLU intervened in that suit, representing a group of 4 patients and a doctor in Oregon who have prescription records in the database who were concerned about their personal privacy and the potential violation of their Fourth Amendment rights. And just a couple months ago, a federal judge in Oregon sided with us and said that, the information about your prescription history and your medical information is about the most private information there is, and the warrant requirement of the Fourth Amendment absolutely applies. And I guess the last thing I'll say about it is that the government makes a couple of arguments to try to respond to that. The one they try to press most forcefully is, I think, the most offensive, which is the under Fourth Amendment doctrine, there's this thing called the third-party doctrine, which is the principle that if you voluntarily share information with a third party, whoever that might be, then you are deemed to have given up your privacy interest in it as to law enforcement. So this happens with phone metadata, the numbers you call, you share them with your phone company, therefore law enforcement should be able to go to the phone company and get them without a warrant. They were making this argument in the context of medical records, the mere act of going to your doctor and sharing your health information and then bringing the prescription to your pharmacist, and then your pharmacist, mandated by law, sharing it with the secure state database. The DEA was saying, waives your privacy interest in it, the Fourth Amendment shouldn't apply, which the judge rightfully just dismissed out of hand, and I think is offensive, but it's also pretty dangerous in this context.
I hope this ACLU is taking direct aim at the third-party doctrine, which is a really extremely anomalous American concept that rose up sort of pre-information age, but is being applied now.
Yeah, I mean, we have litigation in a whole lot of areas. These kind of health records contexts, location tracking, whether your cell phone location information held by your self-service provider can be obtained without a warrant. Lots of other contexts. So it's true that the bigger the data sets about us get in this increasingly digital world, the more ability the government has to go grab very, very precise pictures of who we are, what our health is, where we've been, who our intimate partners are, et cetera. And so the doctrine is from the 1960s. It just makes, I don't think it made sense then, but it certainly makes no sense now.
Right, and so watch the Supreme Court will be issuing their decision in a case called Riley very shortly on cell phones, and it does have relations to the things we're talking about here. Please, your question.
Bill Yasnoff, Health Record Banking Alliance. Deborah, you mentioned that in other countries, people have the ability to individually control their personal information. One of the arguments we hear about that is that allowing people to do that would have all sorts of negative consequences. So naturally, the expectation would be in other countries where they do allow this, there would be all kinds of negative consequences. And I wonder what kind of consequences are actually seen in those countries that do allow people to control their personal information, whether they be positive or negative.
Well, I can imagine one, right? I mean, which my medical colleagues always argue back against me. It's 2 o'clock in the morning. You have a car accident, right? They all keep saying you're unconscious. Only you have this password-protected information up on the web, and the care provider is wanting to care for you. Well, arguably, you could argue back, they don't really need to know everything about your history to know what to do once you've had head trauma, but they will make the argument, I'm not saying I necessarily support this in all respects, that, okay, to get relevant information, to best care for you can't get it.
I want to answer your
respond back to that.
Add to the answer here.
So this means in countries that allow this, there are many unnecessary deaths due to lack of information.
No, that's not the case at all. And I just want to, because we have to close this panel very shortly, but I just want to remind you, and it's on the PPR website, in the 2013 summit, last year's summit, the panel that I moderated, one of the speakers was Peter Boetsma from the Netherlands, who's actually in the audience 4 rows behind you. So please seek him out at the coffee break, and you can go back and watch that video in which he talks about the Netherlands healthcare system, which is an example of this. So that would be a good example. We have to conclude now shortly. I don't want to stand between you and your coffee break. I do want to ask each speaker to tell us, this is the final lightning round here, to tell us one thing in their estimation that could be done. So it actually is possible to be done. One thing that could be done that would most improve protection of health information from surveillance. Nate.
I think in the law enforcement context, state legislatures are our best hope in the near term, and in the PDMP context, Oregon, Rhode Island, Georgia, Arkansas, a really diverse types of states require warrants. There's no reason others can't. This is not a liberal versus conservative issue. It's health privacy appeals to people very intuitively and deeply.
Paul.
I guess I would say make sure that as we evolve our future evolving healthcare system, that the state laws or federal laws can be passed to make sure that proprietary or self-interests don't trump the interests of individuals to get the information that they need and want.
Leah.
So I would say support the emergence of this personal data banking industry that's got little sprouts happening both for medical information and other types of information. Look at what British Columbia has done in Canada. They actually have issued a combined services card for their citizens to access government services and built a triple blind system so that you can use the same card as your driver's license and your healthcare card. But because of how they've architected it literally has 3 steps and 3 totally different databases and really partitioned out the different parts of what it means to authenticate into a system and to give access to records. And that also is the key to your electronic medical record, and that as the province, they are the insurer for everybody because they have universal health care. And aspects of that model could be looked at and applied here, where you get a card and it supports you through many steps getting into your healthcare record, wherever that may be. And also, finally, another thing that they did was in building this system, they had to make choices about how it would work technically, but also policy-wise. And in order to make those choices, after they'd done the key architecture, they said, we could do more with this system. You could log into commercial websites, into many different government services, but before we extend it beyond healthcare, we need to get citizen input. And they actually brought together a panel of 36 randomly selected citizens from around the province that were representative of the diversity there, geographic, age, ethnic groups. 36 of them, they brought them together for 2 whole weekends to explain how the system worked and to ask them what their recommendations were on 5 key future policy choices.
Good. So perhaps
that was the basis of how they're doing it. And I think we need to look at those models of real citizen engagement about policies so that people trust the answers, and it's not just rooms of experts like us.
So perhaps for an action item for next year's summit is to invite Elizabeth Denham, who's the Privacy Commissioner of British Columbia, who could perhaps explain this. Please join me very much in thanking this panel this morning.
Okay, that was great. So we are running a few minutes behind schedule, but we won't take up too much. So we're going to be right back here at 11:05. We have one more panel with Dr. Peter Levin, who's going to talk even more about personal health data. So be sure to join us in about 10 minutes. 11:05. Thanks. All right, so we're going to go ahead and get started. I know there are still people upstairs. They'll be wandering on down. But most of the morning, we've been talking a lot about the personal control of health data and why that's important and all the risks associated with it. But we've left one of the most important topics here as the last panel of the morning, primarily to focus on how do we make sure all of this happens. So did it time out? It's okay. It's just the title slide. So what we're going to talk about today, and Dr. Peter Levin, who just recently left as Chief Technology Officer of VA, and he doesn't like me saying this, but as one of the fathers of the Blue Button, or the father of the Blue Button, has done more for personally controlled health data from an implementation and execution and usage perspective than almost anyone else alive has, and that's why I'm really excited to have him here leading this particular panel about how do we ensure all of the stuff stuff that we just talked about before in the last couple of panels to happen, and that is what is the technology, what are the processes, the procedures, et cetera, to enable that control. And with that, Peter, I'd love for you to take over and go from here.
Thank you, Shahid, for the ever-generous introduction. And welcome to all of you. Very special thanks to my panel members. As a question of format, let me tell you that I'm going to talk for about a minute, and Joy, sitting next to me, is going to talk for about 10. And we're going to leave Ron and Adrian out of the original part of the discussion so that we can get to your questions very, very quickly. So let me try to frame what I think the panel should be about, and then what Ron and Adrian and Joy are going to be able to talk about and share comments and perspective on. So Nathan, in the last panel, told a story that I had never heard before about the illegitimate use of personal health information. I come from a somewhat more sanguine perspective. I'm a little bit more optimistic that in the same way that we drive automobiles even though they're dangerous, and we own guns even though they're dangerous, that we can be, all of us, be trusted with our personal health information. There will, of course, occasionally be bad actors. There will occasionally be criminals who use this information either against us or to exploit us. But from my perspective, we have two choices. We can use data to promote an individual's access to care or work or love, or we can use it to limit data. But by that, we're making, I think, a compromise. A trade space is to not allow public health officials access to it, to not allow insurance companies to help us figure out in a constructive and creative and affirming way to lower our costs. And frankly, we may in fact be constraining, even congesting society's interest to access that data. So on the one hand, we all of us want it, we all of us need it, we all of us by law now are entitled to it. On the other hand, we know that there's an inherent tension in this conversation because the bad people are out there and people who are either not compliant with the law or deliberately breaking it. So that, I think, is really sort of the platform of this discussion. We're going to spend some time talking about rules and regulations and the perspectives that we have. Ron has suggested that we focus his questions and his part of the conversation on the immediacy of access. And are you sure what you're consenting to? So those of us who I would say are forward-leaning, otherwise trusting, signing these forms, most of us without reading them, me among them, do you actually understand where it is that you're taking this conversation? Adrian has suggested that he would like to focus on transaction credentials and patient concurrence. So how do I know you are who you say you are? And very much like Ron, do you understand what it is that you're agreeing to? In the last conversation, I took a note. Adrian was pressing one of the panelists about patient access in Massachusetts. God damn it, I had exactly the same problem in New York City last week. There is a state initiative called the Shiny. If there's anybody here from New York, I would love to bend your ear after this conversation. Exactly the same conversation. The law says you have to, and you're not. Why not? And then last but not least, but most importantly, Joy, who's going to get a lot of airtime, is going to talk to us now about the fair rights of access. So in other words, sort of the positive type, what does the law say about your ability to get your health information, the regulatory frameworks, HIPAA, high-tech, and the CLIA challenges. So Joy, take it away.
Thank you, Peter. And thank you for having me on the panel today. This is one of my favorite topics, as I think everybody knows, about patients' access to their own health information. And one of the things that was very interesting about your introductory remarks was focusing on what you were calling like the bad actors and who use information inappropriately. But there's a flip side of that coin, which is the people who hoard the information from the patient. And that happens still to this day. HIPAA was promulgated, issued a number of years ago, and patients have had a right to request and be able to see and get a copy of their own health information for almost, 14 years now? it should be no surprise to anybody that people have the right of access to their own health information. Yet that still is a major issue for patients trying to get copies of their health records. In the initial set of the HIPAA privacy rule, there was language that patients could request that information in whatever form or format, and that the entities that were holding it were required to give it to them in that format if it was readily producible. There was a lot of discussion over the years about what that actually meant. So when the HITECH Act was enacted in 2009, Congress clarified that that means if you ask for an electronic copy of your health information and it's readily producible, the provider or the plan has to give you your information in an electronic format. So that's really, I mean, that made it pretty clear. There's no question about that. There was another change that came about recently, too. And this is really getting into the weeds in HIPAA. So I kind of apologize to the non-lawyers, but I'll try to keep it as high level as possible. So the way HIPAA was originally written, it had what I would call almost a carve out, that patients had access to all this information from healthcare providers. And healthcare providers is defined very broadly as you know, people and organizations that give you treatment or do analysis. So it includes clinical labs. But there was a carve out in HIPAA that referred to another law, which is referred to as the Clinical Laboratory Improvements Act, CLIA for short, as we call it, and that has its own set of regulations. So between those two acts, the net effect of that is there was a carve out. Patients did not have direct access to their lab test results from a lab. Now, some people might say that's not a big deal. You can always get them from your doctor. But there's been research that's shown that about 7% of the time, providers don't even give patients, notify them of their adverse test results. And so we're talking about life here. We're talking about life and death information that people need to act on. So the way those regulations work together is HIPAA defers to CLIA, and CLIA defers to the state CLIA-based laws. So in some states, you were able to get your lab test results directly from, you could ask for them and the lab would give you your lab test results. But in some of these very large states like California and New York, they had very restrictive provisions on when a lab could, if at all, give a patient's access to their own health information. So it took quite a while. I think we did the first study on this when I was on Georgetown, and it was back in, I think, 2009. And this year, 5 years later, HHS released amendments to CLIA and HIPAA to allow patients to get direct access to their lab test results. So the whole big picture of this is now patients have access, a right of access. And that's really important. It's a right. So when you ask, they're supposed to give it to you, a right of access to get their information electronically from their healthcare providers if they're able to produce it for them. There are very, very limited exceptions to that, about this wide. So that's pretty much the regulatory framework, and I think we're in a pretty good framework now, given all of the devices and apps that are being developed for people, that they will be able to take this information and make it really useful.
Great, thank you. So we wanted to get to questions as quickly as possible. The bios, of course, are in your handouts. If there aren't any questions, I'm perfectly happy to ask a couple, but does anybody want to start us off? Okay, then I will. So, Ron, when you and I were talking briefly, you were explaining that one of the primary problems that you face in this particular topic is that people are, these are my words, not your words, but people are effectively blindly signing their consent away. And then you made the quip, you know, we were thinking that we may have to start Mirandizing people before we put the forms in front of them. Look, you know, Shahid said some outrageously nice things about me, but at the the end of the day, I am very interested in giving people access to their personal health information, and I think that they shouldn't have to be lawyers in order to understand what it is that they need to do and what the protections they have by agreeing to accept it. So can you talk a little bit about what the real problem is, and do you have a proposed solution for it?
So we got into this a little bit this morning. It's a very complex problem, by the way. I don't need to tell this audience that. And I'm going to split the world. We drifted into research world this morning a little bit, and it's important to keep research and non-research distinct, but then also recognize that much of the data that's collected for a research study is not research data. And what I mean is that every research study has the objectives of the study. You see, in my world, something like response rate and survival and so on. But the data points that are actually collected are actually commonly collected in many other non-data type situations. So, and then branching over into pathology and tissue world, which has been the subject of a lot of opinions in the last couple years. When the person signs the consent form, which I agree with this morning's comment is usually presented in a rather perfunctory manner, what parts of what are they signing that consent to? And we spent some time this morning talking as if it was the perspective of all data, and then there's the research limited data elements, and then there's the stuff that, as you heard, goes into some de-identified fashion, and the all people want to include that, and there are people who say, no, let's keep that out. So it gets very complicated very quickly as to how many and what data elements are actually involved. I would say probably on any given clinic visit, I may collect, confirm, or ask a few hundred unique to that person. And getting back to the medical record access stuff, where the same concept applies, we did make our medical record basically a carbon copy of it available to patients. Anybody can access it. They see the same things that I see.
You call it Blue Button?
It's not downloadable. It's not exportable totally yet. It's quasi-exportable in the sense that they get text files for some of the dictations and so on, and certainly are at full reign to copy those and paste them into whatever they want, including a a mining tool that they could mine the word text for different things if they so choose to. But that was a very important concept, to have people have total access. Now, at what time is the other point I wanted to bring up, because in my world, which is cancer world, we deal with those particularly difficult to interpret cancer blood tests, certainly genetic markers, as was mentioned this morning, and other sorts of information like X-ray reports and so on that take a certain, we wanted to make sure we were able to have a discussion with the patient before we just unleashed it out there. So after a heck of a lot of discussion internally, we put a 7-day hold on that. It's totally arbitrary. It's not 30 days. It's not 10 days, not 2 days. And that was to give our clinicians an opportunity then to at least review unexpected results with what the patient we knew was going to see in their version of our EMR, so that it didn't come completely unexpected.
Thank you. Thank you.
Can I comment?
Sure.
We had, HHS received a lot of comments from the physician community about that, they're concerned that patients getting direct access to their lab test results in particular would interfere with the provider-patient relationship. And the preamble does kind of contemplate that there might be this availability, because under the rule itself, you have 30 days. Legally, you have 30 days to provide it. And so the fact that you're giving it to them within 7 still is a very much less time than legally you're required to do.
I might just say, we thought that was going to open the floodgates for phone calls, and it did not. I mean, actually, It just didn't.
So, Adrian, thank you, Ron. So, Adrian, I'm going to put you on the spot. I'm going to throw you a curveball here. I've been waiting a long time to do this, I have to say. So, here's a public health fact. I think you and I would agree to this. That at the very least, we know, I would say with certainty, that 100,000 people die every year in the United States due to avoidable medical errors. From my perspective, that's uncontended. A lot of people think it's more than that. So this is the IOM report. It's a decade old already, so who actually knows? But I don't think that anybody in this room, and I don't think any practicing clinician would argue that it's much lower than that. Many would believe it's higher. Excuse me. So here's the proposition I want to put in front of you. I personally believe that we have grossly overcompensated on the privacy side. I do. One of the conversations that we had when we were launching Blue Button at the VA, and because we had all the conversations that I heard this morning, all the conversations that I read about in preparation, all the conversations that we just heard in Ron's remarks, at the end of the day, it came down to a question of trust. Not do you trust people to comply with the law, but do you trust people to have proper use and utility of their information? And what Secretary Shinseki said at the time was, look, we trusted these people to hold rifles and to fire them in anger in defense of our liberty. And we are not going to give them their health information on a USB stick. That doesn't make sense to me. And that was really the policy inflection, right? It was really the secretary's and the deputy secretary's decision. They went to the general counsel. They went to justice. They spent a lot of time with, talking to the folks at HHS. So from my perspective, we are talking about life and death situations, and I deeply respect and honor the conversation that we heard this morning about all the bad things that can happen. But have we overcompensated? For me, it really is a question. The trade spade is a question of trust and exploitation. Right. What do you think about that?
I think there's another incontrovertible fact of equal or maybe stronger thing, which is that there's $1 trillion of fraud, waste, and abuse built into the U.S. healthcare system. Again, this is Institute of JAMA published facts. I don't think, I think some variation of it has been that number from the Institute of Medicine as well. I'm not entirely sure that the 100,000 number you raised and the $1 trillion that comes from equally reputable sources are entirely unrelated. And the link between them is the lack of quality and the lack of cost transparency that we have in this system. So you can look at privacy in two different ways. I tend to look at it purely from the perspective of fair information practice, which means not consent, but meaningful consent, a meaningful choice to something that you consent to. It means transparency, and it means notice. And I've raised some of those issues in the past couple of days. I can't, I don't know what the alternative is, frankly. The alternative is it's too hard. And, that question came up earlier today, and you just heard it from Ron a second ago. It's too hard. So my question, I would bounce this back, actually, to Joy in the following sense. You very carefully and clearly established that there is now a right of access, which is what this panel is about. And we also understand that it's claimed to be too hard in many cases. We need to have segmentation. We need to have surveillance that's done based on probabilistic matching, because we can't have, voluntary strong IDs. I could go on. Now that we have established that the federal government has established this clear right, and we are still faced 14 years on with the problem that it's too hard, where do we go from here?
I promise I will answer your question, but I'd like to include a little bit more background information because you raised the fair information practices, and one of the key elements of those, in addition to the notice, the transparency, is the individual's ability to see their information and to correct it or amend it. Yeah. So that is really pretty the core of a lot of where the right of access comes from. It is based in the Fair Information Practices. So I would quibble with you, Peter, that privacy includes that right of access, and that when you're doing that computation, you have to figure that in. And I would also say that when you were talking about unnecessary deaths, that right of access could actually be used to help reduce that number.
Oh, that was my point. I agree with
because as you know, I think it was Geisinger that did the demo project with Robert Wood Johnson's, the Open Notes project, where they had the providers actually, who were very reluctant at first. I was interested to hear what you were saying here. They were very reluctant, but they provided their patients open access to all of their notes, and the providers went very reluctant to do it. And at the end of the grant, when the pilot was over, there was not a single doctor who opted not to provide patients information that way anymore.
Great.
So there you go. It's not that hard.
We have a question. Thank you. That was really...
Chris Burrow. This is a question for Ron. So there are now standards in place, DIRECT and the MU2 standard, which line up and make it technologically relatively simple for MD Anderson, which I presume is using 2014 certified EMR system, and I presume you have it all set up because you're MD Anderson. It's technologically simple to produce a summary medical record, a blue button type record, and to send it securely to a patient's secure email address. And there are plenty of systems out there, HealthVault and others, including our own, the iBlue Button system, where patients can receive it. So what do you see as the barrier and the opportunity presented by this new technological development, which is very real? This is not in the future. It's there now.
Yeah. So we actually don't even have to send it anywhere, because when it's immediately available at that 72-hour period, or before that even, about 70% of our notes are done within the first 16 hours. It goes right to the patient's inbox on this, what we call MyMD Anderson for Patients. And so it is... Is that a portal? It is a portal. That's not what he was saying. They get an email that there's something new in your portal. They go to the portal, open it up, and it's their record. Yeah.
Yeah. So I'm echoing Peter Schar's comment of yesterday that allowing someone to see a record is great, but the issue here is allowing the patient to own the digital data and receive it on their own system, so that they will then have it and can share it with others. So I'm just wondering, and I'm not trying to put you on the spot.
No.
Yes, I am. But
that's okay.
But this is really a question for the entire galaxy of provider organizations, and I trained at Baylor, think highly of MD Anderson, and I'm really interested in your perspective on that.
So the other part, the reason why I laughed when you asked the question was, and I think this is part of the reason why Stage 1 is being extended just a little bit, is we in particular are moving our EHR from the one we built to a very large commercial product. So no, we have got an extension for Stage 2 for exactly that purpose. But there's the technical aspects of things like you bring up, and I would say the most important part is really the philosophical part of it. Unless an organization makes the commitment that what you said is true, that this is a shared record that everybody should have access to, and it should be as quickly and immediately as possible. Unless you do that, the technical aspects don't have a chance of coming in play.
I'm going to take moderator prerogative here and very briefly respond to that. I think you mean policy-based access, right? We're not talking about unfettered access. And the short and most compact answer I can give to any technological impediment, whether it's at MD Anderson or at Veterans Affairs or any national health delivery network, is horse feathers. This is an extraordinarily straightforward, easily accomplished plenty of precedent. There may be philosophical issues, there may be policy issues, there may be regulatory, legal, or even clinical issues. I can think of mental health exceptions that we need to talk about. But people are letting the tail wag the dog on this. This is not a technological problem at all.
Thank you. My question is for Joy. First part of the question is, are the health information exchanges like the ones we heard about yesterday in Delaware and Indiana covered entities under HIPAA?
As a general rule, health information exchange organizations are business associates of covered entities. They are set up to provide so whenever you ask a question like this, it's great to go through this. Do they provide health care directly to the patient? No. Are they a health plan? Most of them, I would say no. Now, there may be facts that would bring somebody within that, but for the most part, they're not healthcare providers and they're not health plans. Healthcare clearinghouses, people think that they might be that, but if you look at the definition in HIPAA, it's a very narrow definition, and most of them do not perform those kinds of services. They are not, and they're not covered entities. They are business associates.
But as a business associate, we heard the woman from IMS Health this morning tell us that they consider themselves just an extension of the company that generated and owns the identified data that they're performing useful data analysis on. I'm asking this question because it's become clear in the last 2 days that a big problem with the Blue Button is you can get perhaps one set of records from one provider in one format, and if you have more providers and you keep going and you're successful, you'll end up with records in formats that still need integration in some way for you to usefully take them to your next provider. And it seems the integration puzzle has been solved by the HIEs that are collecting EMRs, clinical records, billing records, and putting them in that mega file. That's where I'd like my Blue Button to take me. First of all, I don't even know which of these exchanges has my interconnected set, but could you guys talk about if a policy question has been raised yet about whether we'll get a Blue Button access to that?
Why don't you take it first?
Yes, and stand by. There was an announcement at the beginning of the week on exactly what you just described. There were some missing software architectural components, very simple ones, by the way, that are now publicly available in the open source. And the number of people, it's a feeding frenzy at the moment, just people who are downloading it, looking at it, and answering exactly the question. This was a well-known, well-understood gap in the use model. I think you've said it extremely well. What may or may not be well-known, it just got announced during the Datapalooza, is that it's available.
Will you push to individuals the identity of the exchanges that have their data?
Yeah, we can set that up. Please.
So I'd like to add my 2 cents on this one. So we recognize that was an issue, and if you look back at the request for information that HHS released for its governance of health information exchange, that question was raised, and the response we got was quite interesting. Let me put it that way. It was not supportive. And what this demonstrates once again is that if there is a notice of proposed rulemaking or an ANPRM, and you support something that's in that, if you don't submit comments that say we support this, I can guarantee you everybody who doesn't like it will be submitting comments, and that's all we have on the record.
Really good point. Really good point.
Scott Mace with Health Leaders. I think a very important missing signatory to the Blue Button Pledge is Epic. I don't know whether Epic is what you're transitioning to, Ron, but I think that we need somehow to get past their unwillingness to, number one, take the pledge, and number two, take these new pieces that you're describing and actually implement that, because until that's in code, a lot of this is not going to matter to millions of Americans whose records are stored in Epic.
Yeah. The fact that Epic is missing from the Blue Button Pledge is well known, and we have laws about that now.
Can you elaborate?
Patients have viewable, downloadable, and transferable rights to their electronic information.
Are you suggesting that patients should be bringing suit against
I'm stating that Epic does not support the Blue Button, and I'm also similarly stating that we have a law that says that every patient has right to their health information.
So since I'm sitting here, I have to say that I want to make really clear that the law says that the patient has to, the law says the patient has a right of access. MU meaningful use incentive payments are considered voluntary, and there is a very and there are all kinds of things that conditions that go along with that. So I think that saying that Blue Button is a voluntary effort, MU is a voluntary effort, we're doing as much as we can to incentivize people to do things in a uniform way. The HIPAA privacy rule does not require people to use these specific standards or ways of making the information interchangeable.
And could I just interject? That's why I used the words I did before. It's more of a organizational and philosophical decision, because we know that a lot of people are bailing out of meaningful use and choosing not to do it, and choosing not to take the voluntary aspects, choosing maybe even not to participate in the Medicare program. And so, you know, it's above that. You have to decide it's important as an organization, that is a shared vision, that you and your patient are collaborators in the delivery of care.
And I would suggest that the patients have to be very much vocal and, you know, demand not only that you, but the vendors and everyone provide view, download, and transmit in a form they can use.
Yes.
That's my point.
I'm confused here.
Yeah, I'm confused. I'm sorry.
I'm genuinely confused. I'm going to go back to the question I tried to ask before, as to how do we interpret a right as we have it now. The first thing you said, Joy, was that it's a right.
Yes.
The last thing you said was that some aspects of the regulations as they stand now are voluntary. Scott asked...
That's not exactly what I said.
Well,
I didn't say HIPAA was voluntary. HIPAA's not voluntary. High-tech amendments to HIPAA are not voluntary. MU, to receive payments under MU is voluntary. And to participate, there's nothing in HIPAA that expressly tells people they have to use Blue Button. So the question, it was a very nuanced question. The answer to the question is very nuanced, is the way I would put it. We have done, and I think through meaningful use and through the Blue Button Initiative, and we have done a lot of work in trying to encourage people to do things in a uniform manner. And the absolute the right is to get it in an electronic form. The right under HIPAA is not to get it in a standardized format. So you have to look at all of these different levers that you might have. I wish it was simpler, and I wish it, I think everybody wishes it was stronger, but ultimately, as you were saying, people can elect not to do MU if they don't want to.
But again, I'm trying to understand the right. How for instance, would MD Anderson be connected to this right? I didn't use the term meaningful use at all.
Or Blue Button, for that matter.
Or any particular Blue Button, or any other particular best practice, or uniformity even. I think we have an opportunity here between the four of us to try and elucidate the answer to Scott's question, or my question, where do we go from here? Is it now a question of patients bringing suit, or is it a question that industry will voluntarily deal with this right in a particular way?
So since a piece of that was directed to us, I will tell you there's been a great deal of discussion, given the vendor that was named earlier and given our decision to go with that vendor, whether to use their non-methodology for doing that, or whether to continue to develop our own and make sure that we are fulfilling exactly what we believe in doing, or, as we said, signing up with them and then taking what we get.
I'm sorry. So what?
I'm sorry. We're running out of time, and there are two more questions.
I'll try and be very quickly, because it's turning out that I may not be as controversial as I like to be. But I just want to speak very briefly to It's Too Hard. Yesterday morning, Saheed was talking about the fact that it's difficult to add the kinds of features and protections to software that we want because they weren't part of the original requirements. And they weren't part of the original requirements because we aren't the customers for anyone in this system as it exists today. It's certainly not too hard. It is hard. I'll have to disagree with you some, Peter. It's going to be hard to do, but it's not technically hard. It's just going to be a lot of work. It's going to take money. It's going to take prioritization. So I just want to suggest, if we are not literally the customer and can't say, I won't buy it or I won't pay for this until, we've got to go out and sue and push and be a massive pain in the ass to the people who have to make the decision that this is going to be hard, but we're going to do it anyway.
So could I just respond to that just a second, what I meant by that? And so I'm taking this only as a patient, because I guarantee everybody in this room has been a patient at least once in their life. Depending on the level of the detail, okay, so the either or, the 100% or no, that's easy. I don't know exactly, and sometime we can philosophize about how many times a day some piece of my medical information is being queried by someone. I mean, if you're really a little paranoid, that could be a lot of times a day. And the technical part is, do I want to get an email, in some secure email in every format, every time that occurs, to respond to someone wants to use your LDH that you had done in 2007? That's obviously one extreme of the question at hand, and the database of who maintains all that accurate information, so I'm not getting an email that was my email like 4 years ago and maybe someone else has that, or maybe I'm not around, all those sorts of things. Is it doable? Of course it's doable. It is extremely complicated. And then there's my side of things. How many emails a day do I want about my PHI anyway? I'm just looking at it from a user of the system.
Great comments. Bettina.
So, Bettina Experton from Umetrics, but as a patient, also as a former practicing oncologist, what HHS has achieved with the new HIPAA rule and CLIA is absolutely transformative for the safety of millions of Americans today. And with the Blue Button initiative, which Peter Levin has championed at the VA, you do have today the standards which meet the meaningful use, view, and download transmit standards. And you do have the tools for me, the patient, to assemble on my application, on my device, or my application on my PC, all those various Blue Button or otherwise CCD record coming even from an Epic system, so that I can assemble all that information in a meaningful way, with my application, Blue Button takes one tap of a button securely on my own device. We do all the transformation, all the aggregation, all the normalization, because we work with standards. And it's transformative. Everyone can use those tools today. The word has to be out. This is about life and death, as you say so well, Joy. Thank you.
Well, we are standing between you and your lunch. Thank you very much for the panelists. I personally don't like boring panels, and I don't think that this one was especially calm, which is great. Thank you all for your terrific questions, and let's also thank Shahid for moderating. I'm honored from here.
Thank you for moderating it.
Thank you.
So, as a consummate professional, Peter got us back on time. That's great. So, we have lunch starting at the Hyatt, same place we had the dinner last night. Please don't forget that we'd like for you to fill out the surveys for the conference, and Deb will say a few closing remarks.
Well, the first thing I would like to do is recognize Larry. Larry has been doing all of the incredible accommodation to our speakers and with the lights and video recording. And Larry, you are absolutely brilliant, and we could never have done this without you. So everybody wave at Larry. Thank you. Thank you so much. Okay, so you don't want to miss this lunch because Adam Tanner is really a spectacular investigative reporter, and you're going to very much enjoy what he has to teach us about re-identification. And so, see you in a few minutes. Thank you.
Thank you.
Thank you all.